I get into our specific uh, talk for today, I do want to just let you know about a couple upcoming opportunities. So first, right here in this room on December 10th from 4 to 5:30 p.m., we'll be hosting a global health career panel, be our last event of the semester. Anybody who's interested in careers in global health, I highly recommend you attend. We'll have 4 great panelists who will talk about all different types of careers in global health, from industry to academia and research to education. So please join if you can. I also just want to mention that the site that we're going to be talking about today in Western Kenya is one in which fourth-year medical students are able to rotate as part of our international medical exchange program. So if anyone is interested in learning more about that, please feel free to reach out to us, especially those who will be fourth-year med students next year. It's a great opportunity to start thinking about travel as part of your medical school education. I also want to really acknowledge the sponsor for our Global Health Grand Round lecture series. The Galkin Lecture was endowed by Mr. Arnold Galkin in honor of his son, Paul Galkin, who had died of a rapidly advancing malignancy. Mr. Galkin has been a generous patron of both the Miriam Hospital and Brown University in the past, and wanted to establish this lecture to honor his son, who had been a very accomplished young man, a patron of the local arts, and a pioneer in modern architectural design. So we thank them for their funding tonight. I'm very pleased to introduce our 2 speakers for this evening, who are collaborating together in a really wonderful project ongoing in Western Kenya. Our first speaker is Dr. Elias, who is a faculty member in the Department of Family Medicine, Medical Education, and Community Health at Moi University in Western Kenya. He is a program director of the Higher Diploma in Palliative and Hospice Care for Clinical Officers at the College of Health Sciences at Moi Teaching and Referral Hospital, and he also consults for Living Room International Hospital and is a co-director of the Empath Palliative Care Program. During his training in family medicine, most of his direct clinical experience occurred in the context of primary care networks, and this is the context in which he continues to provide direct clinical care and where he has developed new systems to enhance continuity of care. He has conducted research, presented abstracts in local and international conferences, and published in peer-reviewed journals. He currently serves as the co-principal investigator for implementing point-of-care ultrasound, also known as POCUS, education and care integration throughout Western Kenya to enhance patient-centered primary care. This is a multi-year innovative POCUS implementation program for primary care facilities in Western Kenya, focusing on breast, obstetrics, and cardiopulmonary care. I am also pleased to introduce our own Dr. Szkwarko, who is an associate professor in the Department of Family Medicine and director of the Global Health Faculty Development Fellowship in Family Medicine here at the Warren Alpert Medical School of Brown University. Her research interests are in implementing and evaluating educational innovations that help democratize knowledge and improve healthcare access for vulnerable populations globally. Currently, Dr. Szkwarko co-leads the largest multiple-use case point-of-care ultrasound project in the world, launched in August of 2024, which she and Dr. Elias will be talking more about this evening. With funding provided through Panorama Global, the Gates Foundation, Novartis, Eli Lilly, and MSD for Mothers Initiative, Dr. Szkwarko and Dr. Elias are aiming to train more than 3,000 healthcare workers across Western Kenya in POCUS. Dr. Szkwarko is a global health expert and is the family medicine lead for the academic model providing access to healthcare, or AMPATH, one of the largest academic global health collaborations, and one in which Brown University has been an active partner for several decades now. At the Warren Alpert Medical School, Dr. Szkwarko serves as the co-director for the Reproductive Health Scholarly Concentration and the co-director of the Health System Science 2 and 4 courses for the Primary Care and Population Medicine program. Clinically, she is a hospitalist at Kent Hospital in Warwick, Rhode Island, and does urgent care and TB infection management at Blackstone Valley Community Healthcare in Central Falls, Rhode Island. I am pleased to welcome them both to talk with all of you tonight.
Yeah, hello everyone. So thank you so much for the introduction. So yeah, my name is Hussein Elias, and I'm a family medicine physician at Moy University, the Department of and a faculty in the Department of Family Medicine, Eldoret, and co-leading this project, point of care ultrasound initiative, which we'll be telling you today about.
That was a fantastic introduction. My name is Daria Szkwarko, also a family medicine physician here at Brown and co-leading this initiative with Dr. Elias.
Yeah. We'd like to appreciate that this initiative is funded by Panorama Global with funding from the Gates Foundation, Novartis, Eli Lilly, and the company, and MSD through its MSD for Mothers initiative. And we also have in-kind software and partial hardware support is provided by Butterfly Network, a global health program. For this ground round, we hope that by the end, you'll be able to describe the significant gaps in access to diagnostic testing in rural areas in LMICs, low middle income countries like Kenya, define point of care ultrasound, how it differs from formal ultrasonography and trends in its use, and summarize methods that can be used to evaluate implementation of a point of care ultrasound and share preliminary results from a large multiple use case POCUS program. Just wanted to mention here as well that these are what we're going to be sharing are preliminary results, and we have consent for all the images that we'll be sharing, and the data that we have, all the consents and the ethical approvals have been obtained for that. For us in the medical space, we know that how essential component imaging, diagnostic imaging is important, and yet an estimated 3.2 billion people globally lack access to it. Looking at more specific, more detailed example of a CT scan, you can see that in LMICs, like most of the countries in Africa, like there are less than 5 CT scans per 1,000,000 people, compared to high-income countries where we have more than 20 CT scans per 1,000,000 people. Our initiative focuses on a diagnostic imaging innovation that serves frontline healthcare workers who work in these diagnostic deserts. Today, I'll be talking about our project in Kenya, which is a country in East Africa and has a population of around 55 million with 70 distinct ethnic groups. English and Swahili are the spoken languages, official languages, and our life expectancy, if you compare it to the US, you can see it's like around approximately 66 years. And if you look at some of the key indicators of health between Kenya and US, there's a big disparity. And you can see our the nurse and doctor patient ratios are much less compared to the US. I want to take you to now a rural Western Kenya where this project is implemented. And our project, a lot of healthcare takes place in a level 2 dispensary, like the one that is shown in that picture there. And these are the kind of roads that we have. And that's the mode of transport. We call it the boda boda. So it's actually a motorbike, and during rainy seasons, it becomes really difficult to access this. So the healthcare workers actually have to walk to serve patients in need. A little background on the AMPATH. So this project takes place through the academic model providing access to healthcare. AMPATH is the largest global network of academic health centers collaborating with host country academic institutions in the world. AMPATH was actually founded like more than 30 years ago as a partnership between Indiana University, Moy Teaching and Referral Hospital, and Moy University, and created one of the Africa's largest and most effective HIV/AIDS program. It is now integrated into a broad system of care reaching more than 300 sites across Western Kenya and a catchment area of 24 million people. That's approximately half of the population in Kenya. This is a bidirectional model with counterpart relationships in every department with a tripartite mission to improve and strengthen care, education, and research. Counterparts work together to share ideas, co-lead programs, and have mutually beneficial opportunities to spend time at the partner site and learn and collaborate. One of the strengths with AMPATH is that it's not a separate institution. It works within the government, the Ministry of Health institution. So it works together with the Ministry of Health. Wanted to give you a brief background of the Ministry of Health Kenya healthcare system, which is traditionally a 6-tier healthcare system, kind of a 6 level, and level 1 is the community health, and goes all the way to level 6, which is the tertiary referral centers. Level 1 and 4, between level 1 and 4, that's the primary care network, which works on the hub and spoke model. And this is the vision, trying to establish primary care networks, a workable or a working primary care network in Kenya. That's the vision, to try and have a universal health coverage. And that's the government initiative, and that's what we are working on. Family medicine is the center of this, because they are the ones who are the core of the primary care network and the frontline service delivery. Moi University trains family medicine physicians. So a little about our program at Moi University. So as you can imagine, when practicing in these settings, there can be a lot of gaps in care, and family medicine plays a unique role in helping to bridge this gap. The field of family medicine is still quite young in Kenya, just started like 20 years ago in 2005, and approximately we have like 50 graduates from the program to date.
So who here has used point of care ultrasound? Okay, a couple of people. Who in the room is a student? Okay, and then faculty, raise your hands. Just trying to see. Okay, so we need to get our students using more POCUS, it seems like. So just to make sure we're all on the same page, what is POCUS? POCUS stands for point of care ultrasound that is performed at the bedside. This allows a treating clinician to conduct bedside ultrasound as part of the history and physical exam, and helps us to make real-time decisions about diagnosis and further management. So this is a really important point to know, that POCUS does not replace formal ultrasound, at least in the way that we're defining it. POCUS addresses very specific questions. And so what will happen, I'll give you an example of cardiac POCUS. Although at the bedside, you might be able to answer a question about whether the ejection fraction is reduced, you still might want to get that echocardiogram for a formal diagnosis. It might help you to start a patient on diuretics to get them the treatment that they need, but the echocardiogram is going to give you a lot of more detailed information. So let's consider the rapid evolution of ultrasound technology to really contextualize the innovation that we're going to share with you later. So this is really meant to be a broad overview and by no means exhaustive. So the story of POCUS starts in the mid-20th century, when it was first demonstrated that ultrasound waves could be converted to a dynamic image and used in medical imaging. And then for much of the subsequent 30 years, ultrasound imaging was reserved for diagnostic imaging, but it wasn't really until the 1980s that physicians started using this technology at the bedside, sort of laying the foundation for what we think of now as POCUS. And then in the mid-2010s, POCUS at the bedside became even easier as we had handheld devices started to come out into the market. And it was around this time that machine learning applications in POCUS really started to emerge. And though they're limited, I think right now we're really in a time where there's a rapid evolution of artificial and augmented intelligent technology for ultrasound. And since that evolution, we've seen more and more evidence suggesting that POCUS is an important tool, particularly in primary care, and has an impact across multiple use cases like obstetrics, cardiac, and breast cancer, which are the topics our project is going to focus on. So I hope we've convinced you that POCUS indeed is a tool that can make a difference. So let's tell you our POCUS story. Dr. Hussein?
So the POCUS story, actually, the collaboration of point of care ultrasound story begins in 2016. At that time, I was still part one, like registrar. My early years, registrar is a resident equivalent here, and Dr. Daria was a junior faculty and was a global health fellow. And at that time, she used to spend like a couple of months in Kenya, and we used to be together in a hospital called Webuye County Hospital. We used to spend some time, and we used to drive 10 kilometers to Milo Health Center, which is like just a level 3 facility, and Webuye County Hospital is a level 4. And at that time, getting a formal sonography was challenging, was difficult, especially when we used to go there. And even like affordability of getting a formal sonography was challenging. So we realized that, I mean, POCUS became like, there was a huge need of even having POCUS at that point, especially as you're waiting to get a formal imaging. So through a SonoCare grant from Sonosite, we obtained one of the first portable ultrasound machines. And everywhere we went, the family medicine team went, we walked around with that machine. We scanned pregnant mothers, diagnosed DVTs, identified heart failure, evaluated abscesses, and found pneumonias in the lung. You can see the picture of the machine there, and that's the family medicine team with Dr. Daria in the center. So we scanned, we reviewed images, and taught ourselves point of care ultrasound from whatever books we could get our hands on, and we scanned more. We used to carry this 25-pound machine with us everywhere, gain some muscle. Since we have the pocket devices, I think things have changed.
So in 2017, family medicine continued to see the value of point of care ultrasound in settings like Kenya, and we worked with family medicine experts in POCUS to host one of the largest POCUS trainings in the country of Kenya. And we trained more than 90% of the family medicine physicians in the country over 3 days at Kenyatta University in Nairobi. And shortly after, 2 of our instructors, Drs. Kevin Bergman and Mena Ramos, and some of their other colleagues from Contra Costa, actually went on to found the Global Ultrasound Institute, which is actually one of our key POCUS education partners. So they're a key part of the story. And GUSI really helps to provide comprehensive POCUS training that's accessible to healthcare workers across the globe. However, as one of our team's studies has showed, cost of ultrasound machine and insufficient training, particularly longitudinal mentorship, remain major barriers to really integrating POCUS into practice. And around the same time, as you've heard, low-cost ultrasound probes, like the ones made by Butterfly and GE Healthcare, that we've used in year 1 of our project, hit the market, potentially addressing some of the challenges that our team's study had found.
Yep, taking you back to Kenya. So Swahili saying, haraka haraka haina baraka, pole pole ndo mendo. That means hurry hurry has no blessings, slowly is the right way. So remember, our journey started in 2016, and after 7 revisions, a 45-page proposal, and 1 year later, we successfully received the $6.5 million to support the POCUS initiative that was only in our dreams. We'll spend now the rest of our presentation describing the innovation with a focus on how POCUS education and integration can help close care gaps. We'll also share with you on our evaluation strategy that could be used for other care programs you might be overseeing. We'll also share some of results after 1 year of our program implementation. Our program focuses on 3 important topics, which is improving early recognition and appropriate referral of obstetric complications in the 2nd and 3rd trimester, improve early diagnosis and referral of heart failure, and improve early diagnosis and referral of breast cancer. So that's the map of Kenya, and I want to take you to Western Kenya. Yes, so Bungoma County is where we are implementing first. So the project aims we plan to work with 6 counties over a 4-year period, and each county will receive approximately 100 probes. We'll train approximately 3,000 healthcare workers. Those are nurses, midwives, clinical officers, which are equivalent to physician assistants, and medical officers. Bungoma County being the first county, and we anticipate the trained healthcare workers at the end of 4 years to have conducted at least 300,000 OB scans, 150,000 cardiac scans, and 100,000 breast focus scans. Let me take you now closer to Bungoma. The map that you see there are just the facilities. Blue are level 2, pink is level 3, and if you see a plus sign anywhere, like kind of a red cross, that's level 4 facilities. So as I described earlier, the MOH is shifting to a hub and spoke model of care, and we want to build on that MOH hub and spoke model of care, where level 4 is a hub facility that will serve as POCUS innovation centers, where more specialized imaging will occur and additional training can take place with POCUS experts and educators. In turn, these facilities then will support the lower level facilities, utilizing POCUS in primary care and serve as a referral center for lower level facilities.
So our POCUS innovation has several key components. So first, we're building upon that primary care network hub that we just talked about, and really creating POCUS innovation centers. And so within that center, we're training POCUS champions, and our champions are healthcare workers broadly trained in POCUS who will serve as instructors for subsequent trainings and provide longitudinal mentorship after trainings. We're training healthcare workers in cardiopulmonary, breast, and obstetrical POCUS in collaboration with Gussie. They're the education organization we mentioned earlier, and this is being done through in-person workshops and then also asynchronous online training. Longitudinal mentorship and continuing education for POCUS trained healthcare workers will be provided using Project ECHO, which is an innovative telementoring model that democratizes specialist knowledge to rural communities. And then mobile health learning communities, we use WhatsApp, which is an encrypted platform where folks can share de-identified images and get additional support from POCUS champions. So Webuye is in Bungoma County and has a population of 1.6 million people. It's one of the largest hospitals in the county and only offers X-ray and formal ultrasound, and only just a couple of topics, actually. It was chosen as the POCUS Innovation Center for Bungoma County. On January 13th of this year, we launched the project in Bungoma County, and the event was highly attended by the County Director of Health, Sub-County Ministry of Health representatives, POCUS Innovation Center participants, AMPATH leadership, Gussie leadership. We had some device manufacturer representatives, and folks from our very own Brown Family Medicine Department. We had 68 people join the welcome ceremony to witness a ceremonial memorandum of understanding handover. And this is an image from that launch.
On the same day, we launched the training for our Innovation Center participants. The training included introduction to devices, POCUS training on the 3 topics, as you mentioned, and the key aspects like shifts in referral algorithms and how to get technical support. The process from facility selection to device deployment includes several steps. After selecting facilities, we selected participants within those facilities and send them to registration, send them the registration information where they had to register. Then from there, we assign them the online modules prior to attend the in-person training. And then they came for the in-person training and completed several educational components prior to device deployment. So these are the steps that it took from facility selection to device deployment. POCUS education is, of course, an important component of our project. First, all participants were asked to complete the assigned online modules through the Global Ultrasound Institute online platform. The specific courses were created for the purpose of this project. And following that, there was an in-person Innovation Center training which took place, which was conducted over a period of 10 days and included like the didactic skills and clinical on each topic. The sub-county trainings were 8 days. Those are subsequent trainings which took place in the lower level facilities. And before the in-person training, the participants must have completed at least 50% of the online modules. And at the end of the in-person training, an OSCE was conducted to evaluate the skills and confidence. The project has involved the creation of clinical care algorithms because POCUS is an innovation and it's something new that we are bringing in those devices. So we had to come up with and create clinical care algorithms so that healthcare workers know which patients should be referred for higher level of care. And here is an example of a cardiopulmonary clinical care algorithm. We are scanning individuals with hypertension or diabetes who have signs and symptoms of heart failure. And our cardiac POCUS algorithm includes several key questions like those shown here about the ejection fraction, is the right side of the heart enlarged, pericardial effusion. So depending on the findings, here we have an algorithm as to which the patient should be referred to. For example, a patient who has decreased ejection fraction may be started on diuretics, but it will also be referred to get a formal echocardiography. We'd like to also share some of the POCUS key questions that we are teaching on. And again, it's important to emphasize that POCUS helps us to answer very specific questions that allow a healthcare worker to make a decision on the next steps of care. So for obstetrics, we have like 5 key questions, like asking about the presentation, if it's breech, cephalic, what is the position of the placenta, the fetal heart rate, if it's normal, increased, reduced, or absent, is there a single or multiple pregnancy, and the adequacy of the amniotic fluid. For cardiac, asking, teaching on ejection fraction, right side of the heart, if it's enlarged, is there a pericardial effusion, and is the inferior vena cava compressible? For lungs, asking, looking for the A lines, B lines, is there a pleural effusion, and is there consolidation, and is there lung sliding? For breast, try to simplify it if you see a lesion, and if the lesion is a simple cyst or not.
All right. So as you can see, the POCUS innovation is a phenomenal endeavor and one that's really been years in the making to really figure out all the components that go into it. But at the end of the day, if you just take the POCUS device on its own, or just even the educational component on its own, that's not going to change health outcomes, right? So with the implementation of any care and education program, especially one of this magnitude, we have to ask, how can we be sure that such a large care and education program is actually effective? So to answer this question, I hope this all looks familiar to you. So we have to start with the concept of implementation science. Who here in the room has heard about implementation science? Raise your hand. Okay, not everybody. This is great. So let's consider implementation science to be a bridge, like our pedestrian bridge here in Providence. It's the bridge between research and clinical practice. So often the evidence for a practice or an intervention is cultivated in highly controlled situations. So, and as many of us in the room are physicians or physicians in training, we also know that life in a busy clinic or in a hospital setting is not a highly controlled setting, right? Not at all. And so there's a mismatch there of where evidence is created and where it sort of needs to end up. So implementation science is the study of methods to promote the adoption and integration of evidence-based practices and interventions into routine healthcare and public health settings to improve our impact on population health. How do we take something we know works in a controlled setting and make it work in the fluctuating chaos of real life, right? How do we get what works to the people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage? So it's likely that most of us are very familiar with effectiveness research, right? So this is the classic research asking if something works. So does baby aspirin taken by pregnant people with risk factors prevent preeclampsia? That's an example. Implementation research is a little bit different. So we're going to break this down. So for this explanation, I need to give credit to Dr. Jeffrey Curran, a researcher out of the University of Arkansas, who published this teaching method on implementation research, and also to the University of Washington Implementation Science Research Hub, which is a really great resource for those of you who are interested in implementation science, and of course to one of our team members who's in the audience, Dr. Carolyn Pierce, who's a faculty in our Department of Family Medicine and helped to create these beautiful slides, and even integrating our very own pedestrian bridge here in Providence. So first, when we start, we have the thing. So this is the intervention, the practice, the innovation we're implementing. So in broad strokes, we have POCUS. Okay, but the thing, that's not enough. We need to do stuff to help people do the thing, right? Maybe that's training, maybe that's educating stakeholders, maybe that's identifying, preparing the champions, maybe that's systematically assessing the facilitators and the barriers that impact the innovation, right? Maybe that's engaging the consumers, adapting existing infrastructure. Implementation strategies are collectively the stuff we do to help people and places do the thing. Okay, but then how do we know if what we're doing is actually working? So implementation outcomes collectively focus on how well people or places are actually doing that thing, okay? So in implementation research, we aren't necessarily focusing on effectiveness outcomes. Instead, we're specifically looking at things like acceptability, appropriateness, cost, feasibility, fidelity, penetration, and sustainability. So putting this all together, implementation research is determining how best to help people and places do the thing, okay? Hopefully that all makes sense. So the purpose of phase one was really all about the facilitators and the barriers, and we were really focusing on acceptability and feasibility of the POCUS innovation. And we used a widely cited and well-known determinant framework called the Consolidated Framework for Implementation Science Research, also known as CFIR. So let me just tell you a little bit about CFIR. So it provides a systematic way to assess and evaluate facilitators and barriers. So it's composed of 5 major domains, including an innovation domain, an outer setting domain, an inner setting domain, individuals domain, and implementation process domains. And each of these domains have their own constructs. So the framework broadly defines these, but for every single specific implementation, they need to really be defined accordingly. So what might be considered outer setting for something that you're implementing might not be the outer setting for something that I'm implementing. Okay, so let's turn back to our POCUS innovation. So this is a project that's intended to be rolled out in phases, and this is really by design because first we needed the first phase to test the strategies we developed and that have been previously described, and we really needed to study it in the Western Kenyan context so that with each additional phase, we're really strengthening the approach to implementation so that the implementation of POCUS really translates to real improvements in health outcomes in Western Kenya. So in the first year, we proposed to pilot and adapt implementation strategies to identify the implementation outcomes that will be used in phase 2, assess acceptability, and then assess feasibility. And for both of those, looking at and identifying facilitators and barriers that impact both of those outcomes. All right, so on the right of the screen, you can see the quantitative outcomes that this project is measuring. And we're able to track how many participants we train, how much POCUS is being performed, self-reported confidence, performance outcomes, referral outcomes, and clinical outcomes. And the outcomes at the bottom over here can be considered proxy measures for feasibility and acceptability. Because if we're able to train folks, they're performing POCUS and they're learning something, we can consider that our innovation is feasible. The outcomes towards the top are getting into our effectiveness outcomes, and these are really still in exploration, as you'll see today. When you look over to the left, you can also see our qualitative methods that are really helping us lean into the assessment of feasibility and acceptability of the POCUS innovation, really helping us see what are the barriers and the facilitators in year 1.
We'd like to show you some of our results for year 1. So Bungoma County has 10 sub-counties, and we wanted to be sure that we equitably equipped facilities with the device. So we actually used a facility assessment tool, which helped us to identify the facilities, where our goal was to achieve a 70% facility coverage across all sub-counties. You can see in green, those are the facilities that have been equipped, and red, they're not equipped. We trained a total of 507 healthcare workers that were trained. And we had to plan our training, have 2 sub-counties to be trained at the same time and staggered individuals from the same facilities. This was because so we don't paralyze the healthcare service delivery in those facilities. You can see that some the facilities equipped are quite similar across the sub-counties. And again, this was intentional to achieve our target of 70% of facilities equipped in each sub-county. I want to show you a breakdown of the 507 healthcare workers trained in Bungoma County. And if you look at this table, most healthcare workers that were trained were nurses and clinical officers. That was from level 2 and 3 facilities, which are closest to the community. For context, most medical officers work at facilities that are level 4 or above. In order to capture POCUS use, we are relying on usage data from butterfly devices. As GE at that time was not providing any usage data. And we have 80 facilities that were equipped with butterfly devices and 50 equipped with GE. But these are not mutually exclusive because you can have a facility with both the devices. wanted to share a snapshot of what we have accomplished in year one. We have trained a total of 507 healthcare workers, deployed 144 devices, and equipped 118 facilities. And until recently, we have a total of like slightly more than 6,000 butterfly scan sessions completed across all topical areas after training through the end of October.
So in order to be able to track POCUS use and referral initiation and completion, it's really important to understand the steps involved in documentation. So a healthcare worker uses a POCUS device, and that use is captured by butterfly devices. And as we mentioned, not yet by GE devices, but that's soon to come. So at all facilities, the healthcare worker inputs the scan type and the key findings into a POCUS scan register. And then if a referral is warranted, the healthcare worker initiates a referral, calls the receiving facility, and then documents that referral initiation in the same POCUS scan register. Then the patient hopefully obtains the services, and then the referral outcome is supposed to be communicated back to the referring healthcare worker, who would document completion of that referral. So one important point to mention is that we really want to work hand in hand with the county. And we want to do that because we want to ensure the POCUS care integration and documentation is owned by the county and not by the project. So we could have chosen, and you'll see this in other projects, to pay the healthcare workers to document. We could have paid for a bunch of research assistants to be able to make that documentation happen. But we felt it was really important to work hand in hand with the county. Which means that the documentation is only going to be as strong as the health system itself. And you can imagine that healthcare workers are overworked and they have a lot of documentation responsibilities. But that was important to track if we really want this to be sustainable beyond the project in 4 years. So when we look across facility levels from May through September, we can compare butterfly scan sessions recorded to the scans that were documented in the POCUS scan registers at butterfly facilities. And you can certainly see that we have a bit of a documentation gap. And then if we want to take a closer look at the type of scans that are being performed, we can look at the POCUS scan register data and see that more than half of our scans are in obstetrics. This makes sense given the population that's mostly being seen in clinics. One question we also asked ourselves is whether we can start to get a sense of whether all pregnant patients are getting POCUS scans. So here you can see the estimated pregnant women, total deliveries, and new antenatal clients across our butterfly facilities. You can see the number of all butterfly scan sessions, and we can estimate that approximately 58% of these were OB scans based on detailed butterfly tool usage data. We can also see the documented OB scan number there in purple. And so it's likely that the truth is either closer to the blue line in the middle or maybe between the purple and the blue lines. And that's what we're working to figure out. So this really just demonstrates this data cascade gap in documentation of POCUS scans that are happening. Sometimes this can be because of a POCUS finding that indicates an urgent referral. And for those clinicians in the room, you're not going to prioritize documentation, you're going to prioritize managing the patient, right? So when we asked trained healthcare workers about this, one said, we have to write in the patient file, then in the small register, then later in the main register. Sometimes you can forget to open the main one. And another one said, sometimes we're very busy, especially when there's an emergency. So you do the scan, but you forget to write in the register. Moving on in the cascade and still focusing on OB POCUS as an example, we can see the scans documented in the registers. So these are the key mutually exclusive OB POCUS findings that were documented. For many of these, referral would be warranted, although some patients may still be early in their pregnancy, and we just don't have these data yet. It's something we need to work on collecting in our registers. So assuming that most should have been referred, we can obviously see that there's quite a gap here. So this also likely relates to documentation not being a priority. And we asked healthcare workers their perspective, and one said, we don't know who should check if all the scans are entered or if referrals were followed up. Everyone assumes someone else will do it. Another person said, carrying that long register, we thought it might get worn out so far. These are folks working in the community. You see, carrying a big thing to the community. Here we can look at the referrals that were initiated by type for OB scans. And these are not mutually exclusive, meaning that a patient could be referred for both high-level review and ultrasound. And you can see here also a gap in the data cascade, where we have less than half of referrals initiated being completed. So this also demonstrates a final gap in referral completion, which related to patient barriers in accessing higher level care and also the challenges of communication between the receiving facility and the referring facility. And one healthcare worker said, somebody who'll be going through the POCUS registers, now checking these patients and trying to call them and see if they were assisted for the ultrasound they were sent. One thing we didn't agree to is who should follow up on these referrals. So how can we actually figure out what is happening when we have such a documentation gap? So this is where our mixed methods evaluation using the CFIR framework comes in. Since we learned from our qualitative work that documentation is an issue, we decided to do a deep dive into a subset of facilities to see what's happening. So let's travel together to Szkwarko Health Center, a level 3 facility in Western Kenya. As you can see, the road to Szkwarko can be quite difficult, especially during the rainy season, sometimes completely inaccessible. It's not letting me advance. Okay. And now we're going to take a closer look at OB care, as OB outcomes are well categorized in the Kenyan Health Information System, so it's a nice place for us to start. And we're going to plan to use a similar process of doing deep dives to take a closer look at breast and heart failure outcomes. So when we look at the volume of antenatal and maternity care versus POCUS use at Szkwarko Health Center, we can see that there were about 160 pregnant women in that 3-month period, 52 deliveries, 57 new clients, and about 45 documented OB POCUS scans. There were 45 pregnant clients who received POCUS scans from May through July of this year. Out of these 45, 37 had cephalic presentation. 9 out of the 37 clients went on to have uncomplicated vaginal births. 4 of these 37 clients were still pregnant at the time of data collection. And 2 out of the 45 clients who had POCUS scans did not have any findings documented. And then 2 of the 45 had absent fetal heart rate, and both were referred for higher level of care. And then 1 client was found to have breech presentation and antenatal care at an estimated gestational age of 28 weeks and was still pregnant at the time of data collection. And 3 clients were found to have multiple gestation. All were referred to higher level of care. All 3 of them delivered vaginally, 2 at outside facilities, and 1 at Szkwarko.
So with our CFIR framework, we wanted to further explore individual roles and communication for the patients referred. So we went back to our qualitative team and asked them to purposely interview providers at Szkwarko and also interview the patient and the caregiver and the receiving facility. So at Szkwarko, when they were there, they heard about a case, one of the patients who had twins from a healthcare worker trained in POCUS. And she said they did the scan that was during one of the antenatal care visits. We performed a POCUS and found twins. One was breech, the other cephalic. Both babies had a heartbeat. And then they referred the mother for a formal ultrasound. Okay, yeah. Then we went and talked to the caregiver of the patient, who said they sent us to Webuye to take a big picture. That was meaning a formal ultrasound. But we never went. When labor came, we took a boda. There was the motorbike, if you remember. But we could not reach. We branched in Lugulu. So Lugulu is a faith-based facility, which was also one of our POCUS trained or POCUS equipped site. That's where they went for the delivery. And talking to the patient or to the mother, she said, I went to my nearby facility that was for a routine clinic, and they asked me if I've ever had an ultrasound before. This was my second pregnancy with no ultrasound performed. The nurse poured some gel on my stomach and used an object that was the probe to look at how my baby was continuing, and she instructed me not to come here when labor had started to kick in, and the healthcare workers informed us that we would need to do a cesarean section. Finally, we talked to a healthcare worker trained in POCUS who received feedback from the high-level facility, and she said that the documentation of the POCUS can expedited care for this patient at a high-level facility. She also noted that the patient felt satisfied with the care and was grateful for how the events unfolded. The next step for our phase 2 is to demonstrate whether POCUS is having a population level impact. So we were looking at the breach deliveries and comparing between the months of May and September in 2024 and this year, 2025. And if you look at here, that there is a decrease in the number of, in the percentage of breech vaginal deliveries out of the total number of vaginal deliveries. Although, of course, correlation does not equal causation, and we don't know if this is related to POCUS or not. So we are planning to do a regression analysis to begin the regression analysis to see if POCUS use has independently associated with some of these key outcomes. And the data we are using is the KHIS, that's the Kenyan Health Information Service. We are also conducting deep dives for other topical areas. Our team recently completed data collection at Webuye County Hospital to look at the percentage of admissions related to heart failure before and after POCUS implementation. We are seeing an increase in the number of heart failure admissions, which could be related to POCUS being done in the emergency department and earlier recognition of heart failure. Of course, more analysis is needed, but we wanted to show some of our preliminary findings that suggest POCUS might be having an impact. Wanted to share some of our year 2 targets, which we started this year in September. We plan to train 400 healthcare workers in each county. We plan to distribute 85 probes in Elgeyo Marakwet County and 65 probes in Busia County, equipping 80 facilities and 60 facilities respectively. Looking at a closer look at the EMC Elgeyo Marakwet County, which is here, and Busia right at the end there. These are smaller counties. EMC Elgeyo Marakwet County is topographically challenging. If some of who have been in Kenya, you can actually look at something called the Kerio Valley. So it's actually a county on the valley. I like calling it a vertical county because it's exactly on the valley. We could be seeing the distances are very close, but getting to one point to another point, it might take you an hour or plus just to get those. So that's the challenge that we're having. And if you look at these counties also, although much smaller in terms of population, but the land area is similar to Bungoma. Busia is still smaller, and the number of facilities are much less compared to Bungoma. And if you look at the county, how it is, these are longitudinal, very long counties. So it's a new challenge for us, which and a different terrain, and this is helping us to understand what it is like to implement POCUS in these areas. With the grant-funded projects, it is easy not to think about the sustainability because it's really hard work. It's never easy. However, we don't want to be just like any other another project that succeeds in something like for 4 years, and as the funding ends, everything collapses, everything falls apart. We are thinking about our sustainability strategies and trying to see how we can fully integrate POCUS documentation and reporting onto the mainstream service delivery to ensure long-term adoption across all levels of care. We are working with counties to develop and institutionalize referral guidelines that include POCUS variables, strengthening clinical pathways, and continuity of care. One of the examples is that in Bungoma, we worked with the county to create POCUS scan registers, as you learned about earlier. And in our second county, we learned that they don't want any like manual registers because they are moving fully digital. And we tried to integrate POCUS documentation into that platform, but that would have been, it's very expensive, costing around $20,000 and may take a lot of time. So we are co-creating a digital platform with Global Ultrasound Institute to capture POCUS variables and then working with the county to at least have the referral cascade tracked with an integrated system. This is a lot of extra work, but it also means that we are less likely to contribute to POCUS graveyards after the project ends.
So we need to mention the AI POCUS tools approved for care in the US and in Kenya, because we're going to be integrating them, and we are integrating them already in year 2. So they fall into 2 categories, which we are calling AI guidance versus AI blind sweep. And this might be particularly of interest to clinicians and the future clinicians in the room. So the AI guidance tool we show here in the top is developed by Echo Iris, which is a company based in California in the United States. They have an AI tool that helps the user know when they're finding the correct window. It's almost like playing a video game, to be honest. The tool helps to identify anatomical landmarks and then monitors image quality and provides direct feedback to the user. It also highlights common mistakes to avoid while scanning. Then we have the AI blind sweep, which you can see below. And this one is available by Butterfly, which is also a US-based company. With 3 horizontal sweeps and 3 vertical sweeps, a report is generated with a gestational age. And this is geared towards the novice user who does not have any POCUS experience. It's really important to note that we'll just mention that an image is not included with that report. And so one thing that we've been thinking about as clinicians is how do we advocate for AI tools that might potentially jeopardize benefits of POCUS and the patient-provider relationship if that image is removed from the report. It's just some food for thought as we're thinking about AI tool integration. So the work that we've talked to you about today could not have been accomplished without our very large and fantastic team. And we also really want to thank all of our partners, the device manufacturers, Hatch Technologies, which has really been providing us a lot of technical support, and the Global Ultrasound Institute, our POCUS education partner. And the year has really been filled with a lot of teamwork, which reminds us that we must continue to move at the speed of trust and really ensure that close collaboration with the Ministry of Health and healthcare workers is always the priority. We strongly feel that although AI may decrease some training time and increase confidence, we really have to advocate as clinicians to continue to prioritize the patient-provider relationship and how these tools will never replace that. And of course, we would be nowhere without the support of our partners and kids, some of whom are here today. So thank you to them for everything they do, especially when we are traveling. We could not be global health practitioners without them. Thank you for listening, and we're really happy to take questions.
Yes. So how do you assess the competency after the in-person training? I mean, we can go by referral and the proper referrals, by documentations, but how about those and personal lead? Let's say if I'm trained, I get through the in-person training, then I go back to my original workplace. Then I do a multiple, like 100,000 scans. How to gauge whether it's accurate?
Yeah, that's a great question. And one of the ways that we're doing, so our training is such that, of course, first, the in-person training is you have this contact with the instructor where you are scanning. The second day you are scanning, the instructor is observing you in the clinical areas. Right now you have real patients. And then, of course, there's an OSCE you have to pass. And then after that, so we have worked with Global Ultrasound Institute where they have this a platform where we have images that are being uploaded, and we have reviewers at the back end. So all those images that are being uploaded, the reviewers who are reviewing and assessing for the competency at that point as well. Although I would want to say that we do not have a great image upload because again, how the healthcare workers is trying to not really invest or spend money or giving money to the healthcare workers to that you have to do this, because then at the end everything collapses. Trying to be more pragmatic and saying like in the real life or in the real world how would this work. So yes, so it hasn't been that great, but we're actually working on that and coming up with new strategies.
Because what my concern is, because we're so busy, sometimes they may not have time. And the turnaround for the online platform to get feedbacks maybe take days. And, you have a patient sitting right in front of you, you have to make calls.
Exactly.
And so the precise or good amount of information reading is very important. You don't want to make overcalls, right? I mean, you don't want to send someone that actually doing well, and there is, and unnecessary referrals. And have you guys looking into those, like quality of the referral? I know the documentation is lacking, but with limited information and the read accuracy has been assessed. Once the referral is made, patient went to higher level of care, they have probably repeated the imaging and have we correlate the accuracy?
It's such a great question. And so what we're trying to do with our qualitative team, and we were actually just on a call this morning discussing this, is trying to look for specific cases in the scan register and actually follow the patient's story through the referral process and talk to the healthcare workers about the cases themselves, and then actually bring those back to clinicians to do that cross-check and start to get a sense of what is the accuracy. We've heard success stories, and then of course we've had situations, and I think it's important to share these things. We had a patient who was told that she has twins and then went for a formal ultrasound and she was a singleton, and that was emotionally difficult. And so how do we prepare our team for those ethically challenging scenarios as well, and really creating processes so that we don't cause harm?
So just to add to this, one of the things that we're actually trying to do as well in working with the counties, because the biggest challenge is, a referral is initiated, and then nobody follows up to see what happened to that referral. Did the patient get to the receiving facility, and was the feedback provided? And for us to be able to say that referral was completed is when the feedback was provided to the initiating or the referring facility, and that doesn't happen. So we're actually working with our counties now, and one of the things as part of our sustainability is actually come up with a county referral guideline, which is owned by the county, and they are the ones now who are actively engaged in tracking these referrals. So we have been successful with one of our counties where we are concluding on one of our referral guidelines with them, which is county owned, and they've promised that they're going to be implementing, and they'll be giving us the reports. So let's see how it works. And in addition to that, we also created with Gussie the digital or platform where uploading the images takes you less than 3 minutes. I think that's what they mentioned, the healthcare workers, to input the information on what was the indication, what are the findings, and if you're referring, where are you referring, and the reason for referral. So those are some of the tools that we've come up with.
So we also aim to maybe consider put this POCUS to be covered by SHA maybe down the road. So make it a more sustainable long term beyond the 4 years, because that's a short term.
Great question, great suggestion, and it's an ongoing discussion actually we have, because right now actually SHA is trying to review their benefit package, and we already begun discussions with them to see how best, because the counties are pushing for it. But again, it's not a formal sonography. So how can we, and it's not a formal report that we're giving. It's part of, we look at POCUS as part of our physical exam, a good or an extended physical exam where, or an advanced stethoscope, that you're not only hearing, but you're able to see as well. So how do we, how do we build this, for reimbursement? So those are discussions that we're having. And I would like to share that one of the ideas that we have received is, can we build it as, because POCUS, we have from literature that the POCUS use was limited because of lack of resources. You need a gel, you need a tissue paper or something. And if you don't have that available, then you don't want to use the device. And then there's the device maintenance as well. So it was looking at, can we just put it as kind of a procedural fee, as a procedure, a small amount. So even SHA will be happy, the patients will not feel it as much, and the healthcare facilities will be happy because they'll be getting the reimbursement or what is a good amount is what we have on Saturday. Yeah. Thank you.
I just wanted to say how impressive this work is, the scope, the depth, how deeply you guys have thought about sustainability, and I think the health equity piece. I think it gives me palpitations, like both in excitement for you and anxiety. It's like so much. So it's really, really cool. Congratulations, first off. And then I guess my question kind of dovetails on this. I wonder if one of the strengths that I got from the presentation was the relationship building that you have, right, with these counties and with the healthcare workers and the communities they serve. Could there be a role for, like, in terms of the fidelity piece, having a revisit, like a clinic, a site visit for a repeat OSCE, or just to see how it's being implemented? And I wonder if there, with Gussie and with your program, could there be a train the trainers kind of piece so that people become leaders in their counties and then, you know, you grow?
Great suggestions, great questions, and thank you for the compliment. True, we have thought about this, and one of the things that our project and we are really thinking that that's one of our strengths is the first training that we have, the innovation center. It's a little bit extended, and we have come up with like a tool to identify potential trainers from our innovation center. Like you can have like 24, let's say, healthcare workers that we are training, but not all the 24 would have an interest in becoming trainers. So this tool helps us to identify. So it's kind of more of an objective and subjective combined kind of method to be able to identify. So we identify them and then we bring them on board. Then they spend a couple of days with the instructors to learn how to instruct, and then they participate in the subsequent trainings. Then the instructors then send them off when they feel they're competent enough and feel, okay, this person can be a trainer, and send off. So then at the end of the trainings, because we are training like around 400 workers, and these are like, staged or steps, staggered training. So at the end of the training, then we send them off as champions, depending on how they've performed and how they've built their skills, their, behavior, attitude, and all that. And then we send them off as champions, which are now recognized by the county as champions. And these are the people now who will support, longitudinal mentorship to be able to. So we have this whole process guide that we've created for longitudinal mentorship to see how we can continuously provide to make sure that a good focus is happening, appropriateness, and competent focus is happening out there.
I'll maybe just mention one thing, because I think both of our devices in the first year do offer like a telementoring feature. So we're training our POCUS champions to actually connect with healthcare workers. So because some sites are far away, so doing site visits actually is like time intensive and very expensive. So they're going to be able to connect through the device itself so that the healthcare worker can actually be scanning and then connect via Zoom on their tablet. And then the POCUS champion can actually see what they're scanning and help talk them through some of the challenges. So that's all being implemented, and we've been spearheading that.
And one thing to mention also, like these counties do not have a focal person, but now they have a county focal person who is now leading the POCUS initiative as well and supporting us. So that's the person they're working with.
Also, Ditto, just wanted to congratulate you. It's just such an impressive, thoughtful program that is really obviously deeply connected with the ministry and health system, which is essential for sustainability. We've done a lot of of ultrasound work, more traditional ultrasound in Bangladesh, and we have been aware of some of the new butterfly AI work with obstetric ultrasound for decentralized dating and recognizing certain sensitive multiples, etc. It seemed like you're using, I wasn't clear if you're using POCUS and the butterfly separately, and if the butterfly with the kind of diagnosis is also providing those treatment recommendations. and how well some of that has been validated, not only for OB, but for some of the cardiac and other things, because especially with AI and generative AI, there are a lot of concerns about hallucinations, et cetera. I'm also just curious about what community and your partners, like what their perception is of those kind of AI components that are a little newer.
Yeah.
Especially with the butterfly.
So maybe I'll take the first question and you can weigh in on the community part. So because this is really focused as a care and education program, we are not implementing any AI tools that are not approved by the PPV in Kenya, which is the Poison and Pharmaceutical Board. Did I get that right? That's essentially like the FDA equivalent. And so we sort of wait for that process to happen. And it's only at that point that we will integrate the AI tools. And so right now, the only AI tool that we have to use in Kenya that's PPV approved is the Echo Iris AI tool. And so what we're doing is we're actually training half of our folks in the new county with that AI tool, but they're getting all of the other POCUS training too. So we've integrated it as like an additional half day. And then there's the other half that are just doing POCUS business as usual. And we're going to see what happens and see if there's a change in confidence and use. What are sort of the challenges? What are the perceptions of AI from the healthcare worker perspective? Do you want to speak to that?
Yeah, I mean, it's something that we've just started. Actually, it's still ongoing. I mean, I think the first cohort, we are going to be training and completing training this week, actually, and next week we'll be deploying the devices. And I think a couple of weeks later, we'll be able to get the perspective of the community, what they think and what they feel is about this, and even from the healthcare workers as well. So I think it's soon, if I've understood the question properly, I think it's soon to comment about the community and their thoughts on the AI at this point.
We'll take an online question now.
Nice. This question is from Dr. Rahul Abid. First, he wants to say that it's a great project, really impressive, and congratulations. He's wondering, with improvement in POCUS use in peripheral clinics, the number of patients referred to secondary and tertiary healthcare facilities will be increasing over time. Does the Ministry of Health and other stakeholders have plans to accommodate these increased number of patients for formal ultrasound, echocardiogram, and treatment by improving human resources at these referral health centers?
Great question. And we hope that happens because, I mean, the new insurance system that is at the shop, because it comes as kind of a reimbursement basis. And it's the more services you offer, the more reimbursement you get. So it's kind of a way that the higher level facilities should actually begin improving their services and add more services so that they benefit more from the SHA, get more patients coming in as referred. Because the new system also, what they're trying to do is that they don't want patients to walk in directly to a level 4 hospital, which is the primary care hub. And they want the referrals to come in from level 2s and 3s, vertical referral going to a higher level facility. So we are also trying to build our project on the same model, the hub and spoke model. So yeah, hoping that the government will also continue building.
I have to comment. Thank you for that fantastic question. I think this is in my category of favorite global health ethical question, because really the broader question here is, should we screen for something if we know the health system is not ready? Or do we wait for the health system to be ready until we screen? And I think we've been talking about this for the last decade. And I think we've always felt that if we screen and we can show that there actually are a lot of patients who are suffering from breast cancer, from heart failure, from obstetrical complications, the system will evolve, and we will also have the data to back up the need for that evolution. So thank you for that fantastic question.
That's great. Yeah, why don't we take a question here and then we'll go next there.
Thank you so much for coming to speak to us. I was wondering how you chose to do the training or started in the Bungoma County, because I was looking at the map of where AMPATH and Hawaii University is, and there are other, I guess, like smaller cities. I don't know like what the division is called, but like how did you choose? Like, what were some of the things that made you decide to start there?
So actually, I would say we are biased with me. We wanted to, because this was a new project plan, massive project, and we wanted to do a lot of learning from our year one. So I wanted to also select a very comfortable county. And Bungoma County is a very comfortable county to work with. And family medicine training also happens in Bungoma County. So yeah, so we have good relationships with the county leadership, and we know the people there. And that's where we were able to come up with the new tools that we are using, the algorithms and everything we learned from that. And that's how we ended up with.
Apologies if you already touched on this because I came in late. I'm curious what, after patients have been referred because of various high-risk conditions, what is the level of care they have access to? Like, is there access to like neonatology services? Is maternal fetal medicine like a subspecialty that exists?
Great question. So actually, the highest level of service that they've accessed is again the level 4, which is we have a kind of a 6-level healthcare system. Level 1 is the community. It's totally at the community level, where we have volunteers providing the service. Then level 2 is a dispensary where we just have 1 or 2 nurses providing the care. And level 3 is a bit higher, where some might have some basic inpatient care, but we don't have a medical officer or a doctor there. They just have clinical officers, which are like physician assistant equivalent with prescription rights and nurses. But largely they provide a lot of like antenatal and maternal care at that point. And then level 4 is where now the hospital is, where we have like inpatient. And this could be depending on a 50 to a 250 or 300 bed hospital. And some of this might level 4s might also they have doctors, and some might also have like a family physician, family medicine specialist, or other consultants or other attendings as well, like a surgeon or pediatrician or obs-gyn. So that's the highest level of care that you might find in level 4, and that's the care that they're receiving at that point. And then from there, if they feel now this a patient requires more advanced, then they'll refer to a tertiary center, which is a level 5 or a level 6. But for in our project, our referrals are coming all the way to level 4, and then that's what we are trying to track, but we haven't tracked like after that further work. But we plan to do that.
The design of this study, because obviously it's an implementation science study, but there's also big effectiveness questions you got to a little bit with whether you were having an impact on referrals and outcomes for patients. Did you think about doing this as a randomized cluster design study or like a step wedge design study where you could actually compare intervention and non-intervention sites in order to see causation, whether this actually improved outcomes? And maybe then within that, randomizing different implementation strategies to different sites to see what implementation strategies work best in terms of getting the outcomes you were looking for.
Yeah, such great questions. Thank you for that. So I think in year 1, as we talked about, we really wanted to just make sure that POCUS was acceptable and feasible. And so really in the next 3 years, where we see this as an opportunity each year to think about smaller trials that we can run. So, and they're all going to be incredibly pragmatic, right? And so right now, the pragmatic trial that we have is with Echo Iris, and we are randomizing our trainees into 2 groups, where we have like 1 AI group and 1 non-AI group. And then in the future, what we're envisioning is actually, we've thought about perhaps looking at non-intervention and intervention sites. But one tricky part here is that they're not really doing any POCUS at all. And so the referral systems that we're creating in some counties like EMC, Elgin, Marquette, they will be enrolled across all facilities. But in Bungoma, that POCUS scan register is pretty specific to facilities that have received POCUS. So we would also have to think about like integrating a referral register with POCUS.
Other questions from folks? We have about 10 minutes left, especially students. Yeah, in the back. Yeah, that was not a hand raise. I hallucinated it. Over here, Tanya.
Do you think the POCUS training should be integrated in medical education in general? Right, because it's such a useful skill to have. I'm a pediatrician, but in the US, we don't train pediatricians to have ultrasound skills, but in Europe, some of the programs do. What do you think?
And POCUS is here to stay, honestly. And if you look at the government in Kenya at the moment, they actually want to invest in POCUS. So there'll be a lot of other programs also that they actually want to do more POCUS implementation in other places. So the answer is yes, I think it should be, and it should be part of your, like, when you train your physical exam, you should start engaging with POCUS at that point. So we have thought about this, and we are actually creating a super hub at Moi University and Moi Teaching and Referral Hospital, where we are hoping that from all the clinical departments, we have faculty, just 1 or 2 faculties who we can train with basic, and then from there create champions who will then now think about the curriculum they feel would be appropriate for their trainees and their field. Because there's a demand actually, and we do get, like, from peds oncology, they're saying, like, they need to learn POCUS for, a point of, ultrasound guided, like, IV access and all this, especially in the peds oncology. So yeah, those are kind of things that in the future we hope that will build and grow. But it is something to start with. So we are also creating a simulation lab for POCUS as well at Moi University. Yeah.
I'm curious, is it integrated in family medicine residency training here in the US now?
It is.
It is.
Actually, it started back in 2015, 2016, right around the same time that we were doing this training at Moi. And it certainly evolved over time. I think emergency medicine has really been the specialty that's been ahead in POCUS and how it's been integrated. But the American Academy for Family Physicians has come out during medicals. So it's really incredible to appreciate just in the last 5 to 10 years how many medical schools have truly integrated it into their curriculum.
That's cool. Yeah, it's been part of EM residency training in the US for almost 20 years now, but also EM residency training in Africa. Pretty much all of the African residencies that I know of are also training their residents in ultrasound too.
Yeah, hi. So it's an amazing work and congratulations for you. As I was going through the slides, and I could see that the locations are really, really rural, and I can understand that POCUS is a quite advanced thing there. And me being a former clinician, I've been using POCUS, and yes, documentation was one of the challenge where we were just busy with the patient and we used to miss some time. And I was just once being told that if it's not written, it's not been happening, it's not done. So how do you deal with that challenges where I saw that nurses were complaining about that we are not able to document the findings. And I also want to ask how receptive were the participants about POCUS training, and whether it was voluntary participants or it was the existing healthcare worker where additional POCUS training were added.
I'll take the second one and I'll let you take the first one.
Sorry, I was focusing now on your second question. Can you just summarize?
My first question is, there was challenges with the documentation. So it's probably something which you just do and write it as a history. So how is that being dealt with? Because I face the same challenges while working. I used to miss documenting.
Yeah, absolutely. I'm not sure I have an answer, to be very honest with you. I think we're seeing how this evolves. And I think we're really using all of our data points, both quantitative, qualitative, to understand how documentation could happen and starting to talk to people. So if we notice that a facility is having great success in documentation, we're going to actually send our qualitative team out to them and say, like, tell us what you're doing. How do we actually learn from you? And now bring this to other healthcare workers of, like, here's how this facility has figured out the documentation. I do think we've appreciated that healthcare workers have mentioned that when the POCUS findings are documented in the patient's book, so patients in Kenya often will have like a book that they carry around with them everywhere they go that summarizes all of their healthcare. And so because a lot of the receiving facilities are appreciating the impact that that's having, I think that message is making its way back to other healthcare workers. So I think we just have to hope with time that folks are going to figure out what documentation is really critical to patient care. You'll take the second question.
Yeah, just to add to what she said, also like we are creating like Gussie, we've co-created a digital tool as well, which we hope that, because I mean, what we want them to do, I mean, all the trained participants is upload all the images, all the scans that they're doing, just upload the images. And I think through that, we'll be able to know like, that's one way of trying to do that, because it's an easy process. You do the scan and, upload. And as you're uploading, then there's some information like, some details you're giving regarding the indication, the scan type, what are the findings. So we hope that this works. For now, we know that scanning is happening. I mean, we are so lucky to get like device usage from Butterfly data. So we know scanning is happening. Documentation is not there. This is our plan work on. So coming to your second question about like the willingness of the healthcare worker. That's a great question, actually. One of the things, I don't know, I would like to learn also how do we study the attitudes of participants or healthcare workers, like, they might perform amazing during the training. When it comes to now in the clinical areas, actually doing the scanning, they might probably the numbers are the lowest. And somebody might not perform so well, but would be more curious to do that. So that's something we are also learning and trying to study more around that to see. So what we have tried to do, like we are identifying the facilities through a tool, because we want to get an equitable distribution of devices across the county. And once we do that, then we're actually inviting the participants. So we want to try and invite, more than 50% of the healthcare workers working in that facility. So in case if somebody is away on leave or vacation, or one of the challenges that we face is the random transfers of healthcare workers that happen. So at least somebody else is also trained and will continue with the scanning. So device is just not left. So yeah, and we ask them to register. There's an online platform, like we share the link and we ask them to register. And we do get like everybody registers. But again, for the training, we'll not get always 100% attendance during the training. And then we'll also not get 100% of the people scanning. But we know that more than 80%, I think last month was more than 80% of the facilities were scanning. But everybody was scanning. So that's something we are still figuring it out.
You also asked about the voluntary, or was it? And I think actually, kudos to you, Dr. Hussein. I think he helped with the county, really co-wrote one of the most like detailed, MOUs I've ever seen. Everything to like, look, if we see that facilities aren't using the device, we're going to pull the device. If we don't see that you're coming to the training or you don't have your healthcare workers coming, we're not going to be in your county. And I think that actually, so all of the training messaging doesn't come from AMPATH. It actually comes directly from county leadership. So they are the folks who help to choose the healthcare workers, so they decide actually. They are the ones communicating with them directly. So again, to really emphasize that this is in collaboration and run by the county, which has, I think, been really helpful.
All right, well, we'll wrap up there. Please join me in thanking so much Dr. Elias and Szkwarko for the time.